I'm going to introduce Rod Weil now. Rod is head of commissioning strategy at Luton Clinical Commissioning Group. I should point out in my email earlier in the week I said director is head of commissioning strategy. Rod has worked in NHS commissioning for the past 5 or so years, having previously spent about 20 years working in the pharmaceutical industry in a variety of sales and marketing roles such as Lundbeck, Merck and Cephalon. So he's sat on both sides of the fence. Rod can therefore provide a unique perspective on the challenges faced by both industry and commissioners. He can offer guidance to industry on how to negotiate the complexities of the new NHS and what might be required to facilitate productive partnership working. In his current role, Rod is responsible for working with clinical leaders, partners and the public to develop a local commissioning strategy that improves clinical outcomes within an increasingly tight budget, as we heard from Howard. He is also responsible for ensuring that the strategy is delivered through a team of implementation managers who work closely with clinical leaders to deliver better and more efficient services for the local population. It gives me great pleasure to invite Rod.
Good afternoon, everyone. There's still a few of us bureaucrats around, so I'm not a clinician, but we still have our place for the structures and the process and all the interesting things like that. So thanks very much for the invitation to talk to you this afternoon. I feel really honoured to be talking to you guys today and to be talking amongst a really esteemed panel. So I think some of the things I'm going to say Howard has kind of touched on, so I'll be reinforcing some of those points. And one of the things I wanted to really focus on what are the big concerns for CCGs at the moment? You know, what are the things that are keeping our boards awake at night? And some of those won't be terribly surprising, but hopefully you can help with some of them. So who am I? As Paul said, won't go through this in any other great detail. My job title seems to be a sentence, like many people in the NHS. Essentially, I'm head of strategy, and I'm basically responsible for also making sure that that strategy gets implemented through a team of people. And that strategy needs to deliver our local objectives. There's a lot of local objectives. We also have some national objectives that are mandated to us to deliver. And we must do that within budget. So I've worked for a number of companies before I joined the NHS 4 years ago. Some people in the room will know these companies. Some people in this room will have worked for some of these companies. So Lundbeck, I worked primarily in central nervous system, Alzheimer's, Parkinson's, etc. Merck, now Merck's Rono in Parkinson's disease, and Cephalon, which is now part of the Teva empire. Working in oncology and critical care. So I think that's just to say that I have some background, not necessarily in your therapy areas, but I kind of know where you're coming from and where you're sitting and what your position is. So I want to talk through what really are the key issues for CCGs, what are the things that make us worry, what we need from you as industry, what we want to hear, what are the sort of things we want to hear from you, how potentially can you stay ahead of the game, who could be the key people in CCGs? And finally, just to say a little bit about, well, in the fantasy world where I went back to pharma, would I look at things any differently and would I do things in a different way? Howard's talked very coherently about the new system. I've got a kind of a simplest slide here. And, you know, to be honest, we don't all understand the new system. There's clinical senates, there's networks, goodness me, it's difficult to keep up. But if we look at it very simply, what was the PCT in terms of commissioning? It's gone one of 3 ways. So it's gone to CCGs, it's gone to NHS England, and it's gone to local authorities. So CCGs have nationally around £65 billion worth of commissioning budget. NHS England about 26 billion. And local authorities, largely through public health, the remainder of the budget, which is considerably less than those 2 figures. So CCGs, therefore, are important, and I think organisations that you need to be interfacing with. So, I don't know if you can read all the individual chunks of this slide, but I thought it might be good to give a little bit of context of how a typical CCG spends the money. So this is my organisation, this is Luton, a fairly averagely sized CCG, population of about 215,000 people. The biggest chunk on there is acute care, so big chunk of our spend of that 218 million, that's our overall budget, goes into the hospitals. We have another huge chunk around community services. That's not just our community services provider, it's also things like learning disabilities, continuing healthcare. Mental health is 9%. Urgent care is just at 2%, but just to say that is just the GP bit of urgent care. It's not the hospital bit of urgent care, which falls into the big blue chunk. Medicines at 12%. We have corporate costs, and we have lots of funds and contingencies, which of course we'll never use unless we absolutely have to. But seriously, they are meant to be used for transforming the system to make our system more affordable and better for patients. So that's how the money breaks down. So a summary, I guess, will be this is where we spend the money. We spend it almost 50% of our budget on our local acute trust, which is Luton and Dunstable Hospital. And consequently, that is kind of where we focus a lot of our attention in terms of, are we getting value for money? Are our patients being managed there? Could they be managed elsewhere more effectively and more cheaply? And let's look at how we spend this money, and let's spend it effectively. And is this the best way to channel 50% of our budget into hospitals? It probably isn't the best way. What are the issues for CCGs? There's an organisation called Primary Care Commissioning that do a survey once a quarter of CCGs nationally, looking at what are the big issues on people's minds at the moment. The biggest thing that's coming up at the moment in the most recent survey is not surprisingly money. How are we going to make ends meet? How are we going to break even by the year end? We have limited budget in terms of our management spend. We have a £25 per head limit. That's £25 per head of the local population to spend on corporate and management costs. If you think that PCTs, you're talking about £45 to £50 a head. So there's fewer of us to do rather more of the work. So money's a big issue. The Francis report will be certainly out there on people's minds. That didn't actually come up in the most recent survey with CCGs, but it's certainly something that, locally we're focusing on because we don't want another mid-staffs. Involving the public, I'm going to talk through some of these areas in a bit more depth in a second. Service integration, so how do we join up services around the patient rather than having discrete silos of services. Commissioning support, and engaging our practices. So I'll talk through one or two of these issues in a little bit more depth. So the money, so as Howard already mentioned, we have flat funding since 2010, 2011 in terms of commissioning. And that followed a number of years of really healthy growth that kept totally in parallel to demand and need. So what's happened since 2010-11 is that the funding has become flat, demand hasn't changed, and we are left with a £20 billion gap that we need to close by 2014-15. This is also known as the Nicholson Challenge. It's also known as the QIP Challenge. So this is the context. We need to find this money. Locally, Howard mentioned that in Bexley, their QIP Challenge is, I think, 10.8 million. Ours is 13.5. If we carried on doing what we're doing at the moment, we'll be overspent by 13.5 million at the year end, and heads will roll. So it's a key issue. The Nuffield Trust came out 2 or 3 weeks back and said, well, what happens after 2014-15? Does the problem then go away? Well, no, it doesn't go away, because by 2021-22, so in the nearish future, we could have a gap of 44 to 54 billion unless we get a sudden influx of funding into the NHS, which at the moment doesn't seem terribly likely. So these are issues that are not going to go away. Money is a big issue. What do we do about that? We're beginning to focus more of our resources and management time, clinical time, into prevention and early intervention, self-care. As I alluded to earlier on, it's not just about hospital care. We're trying to look at ways of delivering care out of hospital, nearer to people's homes. And in order to achieve that, to really upskill GPs, community services, to deliver hospital services in the community. GPs as true system gatekeepers, yeah, that's really saying the GP is someone who understands the system, who has a budget delegated by the CCG, they are part of the CCG, and can decide where they use that budget, but to ensure they don't overspend that budget. Joining up services, I'm going to talk a little bit more about in a second. Contract management, so it's about extracting the maximum value from our key contracts with our providers. It's about cost-effective prescribing, and it's about communicating with our patients and saying to the patient, you know, it's not always right that you go to A&E as first point of call. That shouldn't be your first point of call. So a lot of work to do there. I think one of that's something that's been growing, I think, for a few years. It's not just through the recent reforms in the NHS, but there's been an increasing focus on patients, and we've seen this through the Francis Review and the recommendations coming from that. We need to listen more closely to the patients, to the carers, and to their families in terms of what's happening with our services, and actually begin to utilise the voice of people out there to help us design the services. Now, I can't pretend that locally we've got that totally right yet. It's an issue for us. We have a patient reference group in Luton that is largely made up of, well, I guess the key member of that kind of focus group is a 65-year-old white middle-aged gentleman. Luton, if I tell you that 63% of our school kids are now from black and ethnic groups, probably tells you that we've not got the right audience. And we need to work hard to get there. I don't think we've found necessarily the right route to do that yet. So that's an issue for us and will be an issue for other CCGs. I mentioned the integration of services, some work published by an organisation called the Collaboration for Integrated Care and Support. And this made the media 2 or 3 weeks ago, that we want to see integration in all localities across health and social care by 2018. And for the first time, we've seen a definition of what that actually means for the patient. So it's joining up services around the needs of the patient, making those services less complex, easier to negotiate, and easier to work with. So that's an issue for CCGs, is driving that particular agenda forward. On one of the earlier slides, I talked a little about engaging with our practices. We still feels like we're kind of in a new world. And we have a lot of work to do with our GP practices, because some are board members and they're clinical leaders as part of our organisation. But a lot of our practices just see us as the new PCT, when really they haven't seen yet that practices are actually part of the overall organisation. They are commissioners as well as providers, and they can have huge influence over commissioning decisions. And that's a piece of work that we are continually driving to achieve. One final issue just to focus on is commissioning support. This has come out nationally as a subject of concern, that we have these arm's length organisations now, whereas in PCTs everything was done in-house, whereas with CCGs we have commissioning support units, which for us supply things like HR, IT, procurement support and various other things, and most CCGs will utilise a commissioning support unit. Not at the moment are they delivering what seems to be a good commercial offering to us. So that is something that we need to be continually looking at in the future to see, do we have to look at alternatives, in fact, to get our commissioning support? And maybe could industry have a role in that? I don't know, I've not thought that one through, but it's a question perhaps to ponder. Future issues I've just added in red. These are the things that people will be talking about as you interact with CCGs. Are we going to move to local authorities in the future? Andy Burnham came out last week, not the first time, and said he thought that commissioning will be moving to local authorities. CCGs would be advisory groups. I guess my comment to that is, well, let's see if what we've got now is going to work before we start talking about yet another restructure. CCG mergers. We have a huge range of sizes of CCGs, from Corby, which is a population of just under 70,000, through to North East Devon, which is just under 1 million. Now, those smaller CCGs are probably, some of them are going to struggle because the amount of financial risk facing them is heightened because of their size. We will see a continuing move and pressure on some of those smaller CCGs to merge with other CCGs. And the final one I've got on there is around GP disillusionment. We were up in shadow form prior to April this year, and since we were set up in shadow form, our board clinicians have probably, there's been a turnover of around 50%, so half of the GPs who were there at the start have decided it's not for them. They don't like this commissioning lark. Let's get back to the practice and do some real work. That's something we need to keep an eye on. And especially if people come up and tell us that everything's going to change in 2 years' time and GPs will become advisors. So on to what we really need from you. How do you keep ahead of the game? I think, bearing in mind a lot of the stuff I've already said, it's really important to understand those big issues, because when you're going in to see people, to be able to empathise and to understand that there are key issues that go beyond your particular offering, and that CCGs are under a lot of pressure at the moment. I believe you need to understand, when talking to CCGs, you need to understand that local population, what the needs of that population are, and what the CCG's priorities are, what the strategy says, what is the direction of travel. How is your solution? How is it a solution for us? How does it fit into our plans? Evidence, we want to see evidence. We don't want to see this may mean that you get this. We want solid facts, published if possible. These are things you won't have not have heard before. This won't be new to you. But still we get people coming to us, not really with great evidence. We absolutely have to have evidence. And what is the return on investment? Does it mean we can save money in other areas by taking up your offering? And what is the return on investment for patients? What are the real patient outcomes? And repeating, I think, some of what Howard said, think in terms of pathways and not individual bits of the pathway. Think of whole pathways. Who do you need to influence? Probably none of this will come as a great surprise. Medicines management is now generally known as medicines optimization, but they're the same people. They're still very influential because they guide the commissioning organisation in terms of the approach to market access and cost-effective prescribing. So they are key people. You will find with some CCGs that this is a bought-in service, potentially from the commissioning support organisation. We in Luton have this in-house because we believe it's so important to us. But other CCGs, you may find it's kind of at arm's length, which presents a slightly different dynamic. The board-level clinicians clearly are the important leaders, the drivers, the people who set the strategy and the vision moving forward. Like Bexley, we have clinical leaders in a whole variety of areas, so each of our work streams will be headed up by a clinical director who sits on the board, and beneath them there will be a number of largely GP clinical leaders. So it's knowing who these people are. So what's your therapy area? Who is the clinical lead for this? Who's the appropriate person? Commissioning managers, I have a team of 6 commissioning managers, each with a slightly different portfolio. So is it planned care, long-term conditions, urgent care? These people can still, they're bureaucrats still, but they can be very influential. Still very much part of the equation moving forward. Finance, and also people like me who pull together the strategy. So, influencing our strategy, how does your strategy, how does it fit with our strategy? I guess that's the important question we would want to ask you. For example, We have a number of local priorities. We have one around the early detection of cancer, and particularly we have an issue around bowel cancer. It tends to be detected too late. So knowing that, if you're a company that has a product for bowel cancer, that immediately says, okay, that's your need. We have a need there as well. Can we talk? Again, it's not rocket science, but it's knowing what the strategies are. Most CCGs will have, in fact, we've all got a real priority around reducing emergency admissions. How does your product contribute to that? Does it help us reduce the demand on that big blue chunk I showed earlier on? Can it help us reduce that? How does our strategy meet with your strategy? Are there common agendas there? And it's knowing the individual CCGs and the research that I think will get you to the point where you would know that. So how do you influence CCGs with what? I've already talked about this to an extent. You know, what is the real value of your product? It's not just the fact that it's 20 pence a day less expensive. That's great, but you know, we really want more than that. What is the evidence? What are the patient outcomes? What are the real financial outcomes as well? Does it mean that if we invest in your offering, does it mean we'll have to spend less on something else elsewhere? And what is your added value? Can you help us to redesign the pathways, and can we collaborate in that way? So, having been in the NHS for 5 years and finally beginning to understand it, I used to sit there in audience at meetings like this, hearing from people in the NHS singing, I still don't honestly know what you're talking about. I'm beginning to understand. I've tried to keep it simple, but what would I do if I went back to pharma today? I would certainly focus on those products that meet real unmet need. And you know, I've been responsible for products that really, it's like flogging a dead horse. It's been difficult at times because sometimes it's been a global organization and you're absolutely expected to launch that product and deliver the same sales that they're delivering in the US and Europe. If it's not going to work in the UK, just don't try. Not everyone can influence that. But I've learned the hard lesson being in pharma in the past. Empathise with those things that are keeping us awake at night. So don't just come and talk about your product. Understand that we have other needs. It's not just about your product. Think about what, if I went back, I would think about what can I do to provide solutions. And also, who would I work with to provide solutions? So Howard talked about the pathway, coming with a solution around an individual patient pathway. Thinking about a time when I launched into Parkinson's disease, this was a product for early stage Parkinson's. You know, going back, I probably want to work with other organisations who operated in different parts of the pathway, so potentially with organisations who were involved in diagnostics, for example, and think about that partnership working. It doesn't have to be a one company approach. Can there be different companies focusing on different bits of the pathway that together produces an offering to the NHS that becomes tangible and meaningful? Do focus on those people that make the decisions. Don't focus on the call rates. Focus on those people who are really going to make the impact. And the final one there really is just talk to me about solutions. Just don't talk to me about products and what the products deliver. Tell me how that meets my strategy and the solutions I'm looking for. So essentially, in conclusion, I think it's important that you understand where the CCGs are at. You know, we've come through a huge process of authorization, and there's still a lot of issues. Money, Francis, the need to keep our GPs engaged, the need to keep our practices engaged, empathise with that. And know our individual strategies, because they should all be out there on the web. If they're not, they should be. And know very clearly about how you can contribute to the delivery of that strategy. Think very carefully about partnering other organisations. So different organisations operating in different parts of the pathway that can be brought together to produce a bigger whole. And don't forget the evidence and what is the added value for us delivering services for patients. Thank you.
Well, I've got to say, that was terrific. Thank you very much, Rod. I was thinking of a couple of words, but what better than that last slide? Because, when you think about partnerships, think about strategy, understanding customer needs, pathways, the buzzword that we've heard, so key really to both presentations so far. Pathways, how does it make a difference?